Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to another Solid Anatomy lecture. So this is the first of two lectures. This is Deep Face Part 1. And in this lecture, we'll be discussing the muscles, blood vessels, and nerves in the retromandibular fossa. We will also briefly introduce the borders of the temporal and infratemporal fossa and the muscles within these fossa. Also, we'll get into the temporal mandibular joint, or the TMJ, and the muscles of mastication. Part 2 of the lecture will continue the discussion on the deep face by picking back up with the dense infratemporal fossa and then move into the pterygoid palatine fossa. Now, I'll be back later for a clinical correlation and the end of session quiz, but for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
If you've watched the Solid Anatomy lecture on the face and scalp, you may recall that branches of the facial nerve run through the parotid gland before emerging to innervate the muscles of facial expression. The parotid gland, one of the three main salivary glands, is found inferior to the auricle, encapsulated in the investing layer of the deep fascia of the neck. The mostly flat, superficial, or lateral, surface of the gland lies just deep to the skin and spreads anteriorly over the posterior edge of the masseter, the muscle covering the lateral surface of the ramus of the mandible. The parotid duct follows a horizontal course across the masseter, often accompanied by an extension of the gland, and dives into the cheek to pierce the buccinator. The opening of the duct is found in the oral mucosa lateral to the second maxillary molar. The parotid gland sinks into the deep face to fill the retromandibular fossa, which extends from the posterior edge of the ramus of the mandible to the mastoid and styloid processes of the temporal bone. If you are dissecting a cadaver in conjunction with your human anatomy course, you may find yourself stunned and frustrated by the depth of the parotid gland while dissecting the retromandibular fossa. The frustration comes from the tedium of tearing through the substance of the parotid gland in order to isolate the structures occupying the retromandibular fossa. The deep surface of the gland contacts the stylohyoid muscle and the posterior belly of the digastric muscle, which originate from the styloid and mastoid processes of the temporal bone, respectively. Running through the gland in the retromandibular fossa are the aforementioned facial nerve, the retromandibular vein, the external carotid artery and its posterior auricular branch, and the auriculotemporal nerve, a branch of the mandibular division of the trigeminal nerve, which will be discussed later during this lecture in conjunction with the infratemporal fossa. The facial nerve enters the retromandibular fossa by exiting the stylomastoid foramen in the temporal bone as a single branch that immediately divides into a series of motor branches. The first of these branches innervate the adjacent stylohyoid and posterior belly of the digastric. The remaining branches spread out through the parotid gland, emerge from the gland's anterior border, and travel across the face to innervate all of the muscles of facial expression. The retromandibular vein, like most veins in the head, exhibits significant variability. It is commonly formed by a combination of the maxillary vein, which arises from the pterygoid plexus of veins in the infratemporal fossa, and the superficial temporal vein. It generally bifurcates into anterior and posterior divisions. The anterior division usually joins the facial vein to form what is sometimes called the common facial vein, which usually drains into the internal jugular vein in the neck. The posterior division, meanwhile, usually joins the posterior auricular vein to form the external jugular vein. We last saw the external carotid artery in the Solid Anatomy lecture on the anterior triangle of the neck when it was giving off branches such as the occipital, facial, and lingual arteries. It leaves the neck and continues superiorly into the retromandibular fossa. It runs through the deep portion of the parotid gland and gives off the posterior auricular artery, which, as its name suggests, ascends towards the posterior side of the auricle, where it branches extensively to supply several structures, including the external ear and the scalp. Prior to reaching the level of the zygomatic arch, the external carotid bifurcates into its temporal branches, the maxillary artery and the superficial temporal artery. The maxillary artery is still sometimes called the internal maxillary artery. The maxillary artery travels anteriorly and passes deep to the ramus of the mandible to reach the infratemporal fossa. The superficial temporal artery travels superiorly, emerges from the parotid gland, and runs anterior to the auricle in parallel with the auriculotemporal nerve. It gives off the transverse facial artery that, as you may have guessed from its name, runs transversely or horizontally across the face and anastomoses with branches of the facial artery. The superficial temporal artery continues superiorly to supply the scalp. The masseter muscle, which as previously mentioned is partially overlapped by the parotid gland, originates on the zygomatic arch, runs inferiorly on the lateral side of the ramus of the mandible, and inserts on the lateral side of the angle of the mandible. It is supplied by masseteric branches of the maxillary artery and the mandibular division of the trigeminal nerve that originate in the infratemporal fossa and reach the muscle by passing through the mandibular notch, which is between the condylar and coronoid processes of the mandible. The specific actions of this muscle of mastication will be described shortly. The temporal fossa, located on the lateral side of the skull, is filled by another muscle of mastication, the temporalis muscle. The fossa is bounded by the superior temporal line, which forms an arc across the temporal, parietal, and frontal bones, the zygomatic arch, where the superior temporal line ends posteriorly, and the frontal process of the zygomatic bone, where the superior temporal line ends anteriorly. The temporalis muscle originates from the inferior temporal line and the floor of the fossa and is covered by the thick, tough temporalis fascia. The temporalis fascia originates from the superior temporal line and splits inferiorly to attach to the lateral and medial surfaces of the zygomatic arch. The temporalis muscle continues inferiorly past the medial side of the zygomatic arch to attach to the lateral and medial sides of the coronoid process and anterior part of the ramus of the mandible. Like the masseter, it is supplied by branches of the maxillary artery and mandibular division of the trigeminal nerve that originate in the infratemporal fossa. These branches follow a pathway between the zygomatic arch and the lateral surfaces of the sphenoid and temporal bones that connects the temporal fossa to the infratemporal fossa. The infratemporal fossa is bounded laterally by the ramus of the mandible, medially by the lateral pterygoid plate of the sphenoid bone, superiorly by the greater wing of the sphenoid, inferiorly by the attachment of the medial pterygoid muscle to the medial surface of the angle of the mandible, anteriorly by the maxilla, and posteriorly by the temporal bone, specifically its mastoid and styloid processes and its tympanic plate. While most of the temporalis muscle occupies the temporal fossa, the portion that inserts on the medial side of the coronoid process and ramus of the mandible is officially in the infratemporal fossa, since the medial border of this fossa is the ramus of the mandible. Two other muscles of mastication, the medial and lateral pterygoids, are found entirely within the infratemporal fossa. They are named according to the side of the lateral pterygoid plate from which they originate. That is, the medial pterygoid muscle originates from the medial side of the lateral pterygoid plate, while the lateral pterygoid originates from the lateral side of the lateral pterygoid plate. You may recall from the solid anatomy lecture on the skull that the lateral and medial pterygoid plates are parts of the sphenoid bone. Actually, the lateral pterygoid muscle has a superior and an inferior head. The inferior head is the part that originates from the lateral pterygoid plate, while the superior head originates from the greater wing of the sphenoid. Additionally, part of the medial pterygoid originates on the maxilla and the pyramidal process of the palatine bone. The medial pterygoid muscle runs inferolaterally to insert on the medial side of the angle of the mandible, inferior to the mandibular foramen. The inferior head of the lateral pterygoid inserts on the neck of the condylar process of the mandible, while the superior head of the lateral pterygoid inserts on the capsule and articular disc of the temporomandibular joint, which will be discussed now. The muscles of mastication, the masseter, temporalis, and medial and lateral pterygoids act on the temporomandibular joint, which is often abbreviated as the TMJ. The joint is between the head of the mandibular condyle and the squamous portion of the temporal bone, specifically the mandibular fossa posteriorly and the articular tubercle anteriorly. It is a synovial joint that is functionally classified as a modified hinge-type joint. The condylar head is actually separated from the articular surfaces of the temporal bone by an articular disc that is attached at its periphery to the joint capsule. It thus divides the joint capsule into two completely separate superior and inferior synovial compartments that are each lined by a separate synovial membrane. The pterygomandibular joint may thus be thought of as a combination of two joints, a joint between the condylar head and the articular disc, and a joint between the articular disc and the squamous portion of the temporal bone. The joint capsule thickens laterally to form the temporomandibular ligament, or more simply, the lateral ligament, which is the strongest ligament holding the temporomandibular joint together. This ligament is considered to be an intrinsic ligament, since it is part of the joint capsule. Two extrinsic ligaments cross the joint but are too weak to offer it much stability. The stylomandibular ligament connects the styloid process to the angle of the mandible. It is formed from the investing layer of the deep cervical fascia that makes up the fascia covering the deep surface of the parotid gland, and it separates the parotid gland from the submandibular gland. The sphenomandibular ligament runs between the spine of the sphenoid bone, which is found posterolateral to the pterygoid process, and the lingula of the mandible, a superior extension of bone that partially overlaps the mandibular foramen. When muscles of mastication act on the mandible, these extrinsic ligaments both guide and limit the rotational displacement of the mandible with respect to the cranium.
Hi, welcome to another clinical correlation. Now today's lecture is on the anatomy of the deep face. I think that'd be a pretty good name for a band. Anyway, we're paying special attention to mastication, so I'd like to cover a very common medical problem called temporomandibular joint dysfunction syndrome, often referred to as TMJ. Now, TMJ syndrome is an acute or chronic pain, and it's located in the muscles of mastication or inflammation of the temporomandibular joint. Now, TMJ has several predisposing causes, and this is going to include jaw clenching, jaw malocclusion, stress, bruxism. You guys know what that is? That's grinding of the teeth, and that's especially at night. And rarely trauma. Also, be aware that patients can get osteoarthritis or even rheumatoid arthritis in this joint area as well. So who specifically gets TMJ? What type of patients are you going to see most often get this? Well, typically we see this in young women in the 3rd or 4th decade of life. The pain is often unilateral and, as expected, involves the muscles of mastication. You can see radiation of the pain to the jaw, to the ear, and to the posterior cervical region. It's described as a dull ache, and it tends to worsen with chewing. Sometimes there will even be an audible click with jaw movement. Now, these clicks are associated with articular disc displacement. Now, on examination, you want to ask the patient to open and close the mouth, and here you can look for any obvious malocclusion or deviations. Next, you want to palpate the joint with the mouth opened and also closed. Now, often this will elicit tenderness. Radiography is usually not that necessary unless you have a disabling pain or a locking thing that's going on as well. In that case, an MRI is actually the best choice. For management, you want to try to recognize the predisposing factors. If they have malocclusion, then they may need an oral surgeon or an orthodontist. If they have nocturnal jaw clenching or teeth grinding, remember what is that called? Bruxism. Then you can give them mouth guards. Now, realize that mouth guards will prevent loss of tooth enamel due to that grinding, but they may not actually help TMJ. It's probably still worth trying, but in some cases it may actually worsen the TMJ because it kind of causes a little bit of malocclusion just by the changing in position of the mouth. Medications like muscle relaxants, sedatives, tricyclic antidepressants can be used at bedtime, and this will help relax muscles, reduce jaw clenching. Local anesthetics or even corticosteroid joint injections can be used in severe or persisting causes or cases of TMJ. Then finally, if symptoms persist, then you can even do botulinum toxin injections, and this can be used to paralyze some of the muscles of mastication to relieve that pain. All right, guys, so that's enough of my lecturing. Let's answer a few of these questions. First one here, an audible click or crepitus present with jaw movement is often associated with what pathology? Remember, that's going to be your articular disc displacement. Next, we have TMJ is commonly associated with what nighttime activity? Remember, that's that funny word, nocturnal bruxism. About 78% of patients with TMJ will have evidence of grinding and clenching of the teeth at night. All right, guys, so let's get back to that lecture.
Several motions occur about the temporomandibular joint during mastication. Elevation and depression of the mandible cause the mouth to close and open, respectively. Protrusion and retrusion, sometimes referred to jointly as translation, involve anterior and posterior sliding of the mandible, respectively. Additionally, lateral movements of the mandible are possible that allow food to be ground between the teeth. Different motions may be attributed to each of the compartments of the temporomandibular joint. For instance, protrusion and retrusion occur between the disc and the temporal bone, while depression and elevation are movements between the condylar head and the articular disc. Opinions about the actions of the muscles of mastication vary from one source to the next. Generally speaking, the masseter, temporalis, and medial pterygoid are involved in closing the mouth and grinding food between the teeth, while the lateral pterygoid opens the mouth. Here's a list of just the usually agreed upon main actions of each of the four muscles. The masseter and medial pterygoid muscles, which are nearly mirror images of each other and effectively form a sling around to the angle of the mandible, are both elevators of the mandible. The temporalis is an elevator as well, but it also has horizontally oriented fibers that retrude the mandible. The inferior head of the lateral pterygoid protrudes and depresses the mandible, while the main function of the superior head is thought to be pulling the capsule and articular disc of the temporomandibular joint anteriorly to keep these structures positioned properly between the condyle and the mandibular fossa when the mandible is depressed. The buccinator and orbicularis oris are muscles of facial expression, but have a role in mastication as well. They keep food positioned between the maxillary and mandibular teeth and prevent it from collecting in the inferior half of the oral vestibule, the pouch between the teeth and gingivae and the cheek and lips. The tongue assists in the same manner by keeping food from collecting posterior and medial to the teeth and gingivae during chewing. You may recall from the solid anatomy lectures on the neck that the suprahyoid and infrahyoid muscles can work together to depress the mandible. The infrahyoid muscles contract to stabilize the hyoid bone, and then the suprahyoid muscles contract to depress the mandible. Unless you're standing on your head, gravity is sufficient for depression of the mandible. So the action of the suprahyoid and infrahyoid muscles on the mandible is usually stated as depression of the mandible against resistance. Thus, if you had a rubber band around your head that was keeping your mandible elevated, you could depress your mandible against the resistance of the rubber band using your suprahyoid and infrahyoid muscles, as well as your lateral pterygoid. Part of the platysma, another muscle of facial expression, inserts on the inferior margin of the body of the mandible and can also depress the mandible against resistance.
So that covers the lecture on the deep face part 1. Now I want you to pause the video and answer the end of session quiz questions, and then we'll go through those answers together. All right guys, let's get going. First question here. Where is the opening of the parotid duct located? So remember, the oral mucosa lateral to the second maxillary molar. Now it's important to know this area because this is a location that will be pretty subtle in your exam. It's kind of hard to see this. However, the area can become inflamed, and if you take, for instance, like mumps, the whole parotid gland will be enlarged, but the area where it exits into the oral mucosa can also be inflamed as well. Next, what structures run through the parotid gland? So we have the facial nerve, and its most noted structure, but also you're going to see something called the retromandibular vein. You're also going to see the external carotid artery and its posterior auricular branch. The auriculotemporal nerve, and that's a branch of the mandibular division of the trigeminal nerve. So try to remember all of those. Next question. From what foramen does the facial nerve enter the retromandibular fossa? What cranial bone is the foramen located? The facial nerve enters the retromandibular fossa through the stylomastoid foramen, which is in the temporal bone. After entering as a single branch, it then tends to immediately divide into a series of motor branches. Next question. What structures go through the mandibular notch? So the mandibular notch is the area between the condylar and the coronoid process of the mandible. Now the masseteric branches of the maxillary artery and the mandibular division of the trigeminal nerve go through this mandibular notch. Now the masseteric branches of the maxillary artery will supply the masseter muscle, of course, and then the trigeminal nerve is going to innervate it. Next question. Which muscle of mastication fills the temporal fossa? That's going to be the temporalis muscle. Next question. Which muscles of mastication fill the infratemporal fossa? That's going to be your medial and lateral pterygoids. Next. Given the following TMJ muscle, complete the corresponding actions. So we're going to give you the muscle and see what happens. So first we have the masseter, and that's going to elevate the mandible. Inferior head of the lateral pterygoid, that's going to be protrudes the mandible. Temporalis is going to elevate the mandible. It's also going to protrude the mandible as well. Medial pterygoid, that's going to elevate the mandible. Next question. What two joints make up the TMJ? So the first one is the joint between the condylar head and the auricular disc. The second is the joint between the articular disc and the squamous portion of the temporal bone. Next, what are the extrinsic muscle ligaments of the TMJ? What are the intrinsic ligaments of the TMJ? So the extrinsic is the stylomandibular and the sphenomandibular. The intrinsic is going to be the temporal mandibular ligament. All right, guys, so we're almost done. Now we've provided some images once again for you to label. Recalling these images in a time setting will help you to perform well on the practical part of your examination. So label the images and then we'll be finished. Thanks.